If you look at the human body from a strictly engineering perspective, the skull is essentially a fortress.
Right, it's the ultimate biological vault.
Exactly. You have this thick, unyielding bone all the way around. It creates a hard shell designed to protect the single most precious, delicate asset we possess, the central processing unit, the brain.
And it is a highly effective, almost binary design. I mean, it's closed off, heavily armored, prioritizing absolute protection above all other considerations.
But then you travel just a few inches down, and you look at the neck. And suddenly, that impenetrable fortress analogy completely falls apart.
It really does, because the neck isn't a fortress at all.
Not even close. If the skull is the vault, the neck is the vital gateway. It's the drawbridge, the supply line. I mean, next time you turn your head to check your blind spot while driving, just think about what is happening in that space.
It is arguably the most complex, high-stakes piece of anatomical real estate in the entire human body.
And that is the perfect framing for our deep dive today. We are looking at the textbook of Head and Neck Anatomy by Hyatt and Gardner, specifically Chapter 7, to really unpack this.
Yes, because we are not just exploring a junction box here. We're looking at a tightly packed, living conduit.
Right. You've got the respiratory system bringing in air, the digestive system bringing in fuel, the central nervous system's primary wiring.
And massive vascular highways, all coexisting under extreme spatial constraint.
It's so crowded. Everything that sustains the brain must pass up through here. And everything that expresses the brain's intent must pass down.
Precisely. The pedagogical goal of this text isn't just about memorizing isolated facts. It is about building a spatial and functional mental model.
Which is crucial, right?
Absolutely. Anatomy is the study of structure in service of function. And today we are dissecting how that specific structure dictates clinical realities, interventions, and disease outcomes.
So to really understand how this space works, without everything just getting tangled into a massive knot, I want to take this layer by layer.
A very logical approach.
Let's invite you, the listener, to mentally peel back the outer wrapper and work our way into the deep, vital core with us. Starting right at the surface, with the skin itself, there's a brilliant engineering detail here regarding how the skin actually drapes over the neck.
Ah, you're referring to the tension lines, or Langer lines.
Right. And this isn't just trivia, is it? It changes how you literally approach the body with a scalpel.
Oh, completely. If a surgeon needs to make an incision on the neck, they don't just cut anywhere. They aim for horizontal lines.
Because of the grain of the skin.
Yes, the skin's natural grain. The alignment of the collagen fibers in the dermis runs horizontally around the circumference of the neck, almost like a series of stacked rings.
Oh, I see.
So, if a surgeon makes an incision parallel to those horizontal Langer lines, the scalpel is separating the collagen bundles rather than severing them.
So, if the skin heals better horizontally, it must mean the natural tension of the tissue is pulling that way.
Exactly. A vertical cut would constantly be pulled apart every time you move your head.
That sounds painful.
It is, and it's the biomechanical reality. A vertical incision fights the natural tension, leading to a wide, highly visible, hypertrophic scar.
Whereas the horizontal cut.
A horizontal cut heals with a hairline scar that often disappears perfectly into the natural creases of the neck.
Okay, so we slice horizontally, we peel back the skin, and we hit the superficial fascia. It's a thin layer of loose connective tissue, kind of like biological packing peanuts.
That's a good way to visualize the hypodermis, yes.
But embedded right there in this superficial wrapper is something that makes zero logical sense to me. The platysma muscle.
Well, the platysma is a fascinating anomaly.
Anomaly is a very polite word for it. It's a paper-thin sheet of muscle. If you trace its anatomy, it starts way down on the fascia of the chest.
Yes, draped over the pectoralis and deltoid muscles of the shoulder.
Right, and then it sweeps all the way up the entire front of the neck and finally attaches to the lower jaw and the skin of the face. And yet, biologically, it's classified as a muscle of facial expression.
It is, yes.
But it's draping the neck and the chest. Why is a facial muscle covering my collarbone? It's like wearing a shirt collar that is permanently stitched to your cheek.
It does seem like an architectural mistake until you look at the developmental blueprint.
The embryology.
Exactly. This perfectly illustrates how our embryological history dictates our adult anatomy. In the developing embryo, the platysma originates from a structure called the second pharyngeal arch.
So it starts up high near the forming face.
Yes. And because it develops from that specific arch, it is inextricably linked to the wiring of that arch. which is the facial nerve, or cranial nerve 7.
Okay, that makes sense for a facial muscle.
But as the embryo grows and the neck elongates, the tissue that is destined to become the platysma migrates downwards. It slides over the collarbone and onto the chest.
And it just takes the nerve with it.
It does. As it migrates, it drags its nerve supply, its dedicated electrical wire, all the way down with it.
So the blueprint dictates the wiring, regardless of where the muscle ultimately sets up shop.
Yeah.
Even though it's physically on the chest, neurologically, it belongs to the face.
It absolutely does. If you want to feel it work, you can forcefully pull the corners of your mouth down and tense your neck.
Like the expression you make when you are suddenly horrified or straining to lift something incredibly heavy.
Precisely. Those vertical bands that suddenly pop out under the skin of your neck, that is your platysma firing.
Oh, wow. Okay, so lying right there with the platysma in this superficial wrapper, we have some superficial plumbing too. Specifically, the external jugular vein, or the EJV.
The EJV is a crucial landmark. It is formed just behind the angle of the jaw where two smaller veins unite.
Which ones are those?
The posterior auricular vein coming from behind the ear and the retromandibular vein. From there, the EJV descends straight down the side of the neck.
But what makes it so important clinically is its visibility, right?
Oh.
Because it crosses directly over the fleshy belly of a massive muscle.
Yes, the sternocleidomastoid muscle.
Let's pause on that muscle for a second. The sternocleidomastoid, or SCM for short. Looking at the structural layout of the neck, this muscle is the prime meridian. It is the great map maker.
It truly is the defining geographic feature of the neck. I mean, you can feel it easily on yourself.
Right, if you turn your head sharply to the left.
The thick band of muscle that pops out on the right side of your neck, running from behind your ear down to your collarbone, that is the right SCM.
And the name is actually a perfect roadmap of where it anchors. Sternocleidomastoid.
Spot on. It originates from two heads inferiorly, one on the manubrium, which is that little shield-shaped bone right at the top of your sternum.
And the other?
The other is on the medial third of the clavicle, your collarbone. These two heads merge into a thick belly that passes diagonally upward and backward to insert on the mastoid process.
Which is that hard, bony lump you can feel directly behind your earlobe.
Exactly. And because of this diagonal trajectory, sweeping from the front of the chest to the back of the ear, the SCM neatly bisects the side of the neck into two major geographic zones.
The anterior triangle and the posterior triangle.
Correct. The anterior triangle is located in front of the muscle, and the posterior triangle is located behind it.
So we have this massive diagonal mountain range bisecting the neck. And other structures clearly use it to navigate.
They absolutely do.
Like cutaneous nerves, they provide sensation to the skin, and they emerge right around the midpoint of the SCM's posterior border.
Yes. The transverse cervical and great auricular nerves, for example.
Right. They poke out from the deep tissues, cross the muscle, and branch out. It's like they are using the SCM to find their bearings before spreading out to the surface.
It brings profound order to what could otherwise be a tangled mess of wiring. That midpoint of the SCM's posterior border is actually known as the nerve point of the neck.
Oh, really? Why is that important?
Well, if a clinician needs to numb the skin of the neck for a superficial procedure, they don't have to chase tiny nerves everywhere. They just inject local anesthetic right at that midpoint, and it blocks the entire sensory network radiating from it.
That is brilliant. Such an efficient map. Now let's go back to that external jugular vein, the EJV, that we left crossing over the top of the SCM like a sash. I was reading about how this vein acts as a diagnostic window into the heart.
Oh, yes. The EJV is an incredibly elegant natural pressure gauge for the cardiovascular system. It acts as a venous manometer.
How does that work?
To understand why, we have to look at fluid dynamics. The EJV eventually drains deep down into the subclavian vein, which flows into the right side of the heart.
So it's a direct pipeline returning depleted blood to the heart so it can be pumped to the lungs.
Yes. Now, normally, if a person is standing upright or sitting in a chair, gravity keeps the venous blood pressure low. The EJV is mostly collapsed or only slightly visible near the collarbone.
Makes sense. Gravity pulls the blood down.
But imagine a scenario where the right side of the heart is failing. The pump is weak. It cannot efficiently push blood forward into the lungs.
Meaning you get a backlog, a traffic jam of blood building up in the thoracic cavity.
Exactly. Fluid dynamics dictate that pressure backs up. And because there are no functional valves between the right atrium of the heart and the EJV to stop this backward pressure wave, the fluid column rises.
Oh, I see.
So the EJV visibly engorges, bulging out beneath the skin up to the mandible.
So if a patient is lying back in a dental chair And the dentist notices this massive bulging vein snaking all the way up to the jawline.
That dentist is looking at a massive cardiovascular red flag. Severe engorgement of the EJV in a semi-reclined patient is a critical, immediate diagnostic sign of right-sided heart failure.
Wow.
You don't need a stethoscope or an ultrasound to see that the pump is failing. The neck is literally broadcasting the mechanical failure of the heart right there on the surface.
That is astonishing. A physical gauge on the outside of the body telling you the pressure inside the chest. The SCM itself has a pretty visible clinical correlation too, doesn't it? Torticollis.
Yes, torticollis, often called Ryeneck. It's a condition where the head is persistently turned to one side, and it comes down to the biomechanics of the SCM.
Remind me, what is the exact job of the SCM?
The job of the SCM is to pull the ear down toward the shoulder of the same side, while simultaneously rotating the chin upwards to the opposite side.
So if my right SCM fires, my right ear tilts to my right shoulder, but my chin points up and over to my left.
Precisely. Now, torticollis often results from trauma during birth.
Birth trauma.
Yes. If the infant's neck is excessively stretched or twisted during delivery, it can actually tear some of the muscle fibers inside the SCM. This causes bleeding within the muscle belly.
And blood in a muscle belly usually leads to inflammation, right?
It leads to a small hematoma, which eventually organizes into a fibrous mass, basically scar tissue. And as scar tissue matures, it contracts and shrinks.
Ah, so the muscle physically shortens.
Yes, the scarred SCM becomes a tight, unyielding tether. It constantly pulls the mastoid process down, forcing the child's head into that permanently tilted and rotated posture.
So the physical architecture is warped by the scar, and the functional posture has no choice but to follow.
Exactly. Structure dictates function, or in this case, dysfunction.
Wow. So we've mapped this superficial wrapper. We have the skin grain, the platysma clinging to the facial nerve, the EJV pressure gauge, and the massive SCM dividing the territory.
A very busy surface level.
But here's the burning question. We keep saying the neck is a tightly packed cylinder.
Right.
Airway, food pipe, major arteries pulsing at high pressure. What keeps all of these deeper, chaotic structures organized?
It's a vital question.
I mean, why doesn't the trachea grind against the spine every time we swallow?
That brings us to the organizers of the neck. We're talking about the deep cervical fascia.
Now, fascia is one of those concepts that can be notoriously difficult to visualize. It's not a discrete solid organ like a liver or a lung.
No, it is a vast network of connective tissue.
I try to picture it like the watertight bulkheads of a submarine. You have the outer hull, but inside you have these distinct sealed compartments.
That is a highly accurate mental model, actually, both for structural integrity and for containing danger.
How many compartments are we talking about?
The deep cervical fascia is architecturally divided into three primary layers: the investing fascia, the prevertebral fascia, and the pretracheal fascia.
And what about the blood vessels?
Woven from strands of all three layers, you have a specialized tube called the carotid sheath.
Okay, let's build a submarine. Let's start with the outermost bulkhead, the investing fascia.
This is the superficial layer of the deep fascia. It forms a complete, unbroken collar around the entire neck.
Like a tight turtleneck.
Very much so. If we trace it starting from the back, it anchors to the ligamentum nuchae, the strong ligament running down the back of your neck. From there, it sweeps forward around the sides of the neck.
And what happens when it hits a big muscle?
When it encounters a major muscle, like the trapezius in the back or the SCM in the front, it literally splits in two.
Oh, so it delaminates, wraps around the muscle to sandwich it, and then fuses back together on the other side.
Exactly. It envelops the muscles, continues forward, and eventually meets its counterpart from the other side at the anterior midline of the neck. It is the outermost corset of the deep structures.
Okay, outer hull complete. Now we dive deeper. We need to protect the spine.
That is the role of the prevertebral fascia. As the name suggests, it forms a tough, cylindrical envelope around the vertebral column and all the deep muscles of the back of the neck.
So it creates a solid structural floor.
It does. But there is a vital architectural quirk here. As this fascia passes across the front of the vertebrae, it doesn't just form a single sheet.
What does it do?
It splits into two distinct laminae, or layers, with a gap between them.
And what's in that gap?
Very loose, cobweb-like areolar connective tissue. Keep that in mind because that specific gap is going to become a major clinical nightmare in just a moment.
Noted. Holding a mental pin in the cobwebs in front of the spine. What's the third bulkhead?
The pretracheal fascia. This is a thin, cylindrical layer situated in the front of the neck. Its job is to completely surround the visceral structures.
Like the airway and food pipe.
Yes, it wraps the thyroid gland, the trachea, and the larynx. It also covers the sides of the esophagus. The back wall of this pretracheal fascia, the part separating the esophagus from the spine, is called the buccopharyngeal fascia.
Okay, so we have the outer corset, the spinal envelope, and the visceral wrapper. What about the major blood vessels, like you mentioned earlier?
They get their own dedicated pipeline, the carotid sheath. This is a composite bundle. It pulls tissue from the investing prevertebral and pretracheal layers to form a vertical tube running down each side of the neck.
And what's inside it?
Inside this protective sleeve, you find the vital triad, the common and internal carotid arteries, the internal jugular vein, and the vagus nerve.
Right, so we have all these bulkheads constructed. But from an engineering standpoint, what is the everyday functional point of all this wrapping?
Think about the physical mechanics of a simple swallow, or throwing your head back to look at the sky.
Okay.
When you swallow, your larynx and trachea must elevate sharply and independently. They have to slide up to close the airway.
Right, to keep food out of the lungs.
If the tissues of the neck were solidly glued together, that upward movement would drag the skin, the blood vessels, and the spine along with it. It would cause massive friction and tissue tearing.
Like trying to pull a single thread out of a tightly woven carpet.
Exactly. So these fascial planes act as frictionless gliding surfaces. They isolate function.
Oh, I see.
They allow the vessels in the carotid sheath to pulse forcefully, the trachea to rise and fall, and the muscles to contract, all sliding past one another in a confined space without interfering.
So they are essential for motion. But going back to my submarine analogy, the primary job of a bulkhead is to contain a leak.
Right.
If there's a hull breach in compartment A, you seal the door so the whole sub doesn't sink. In the body, I assume these fascial layers usually contain infections, restricting a neck abscess to one specific compartment so it doesn't spread everywhere.
Usually that is true. Fascia provides a tough physical barrier to bacteria. But earlier, you put a mental pin in that gap between the two laminae of the prevertebral fascia.
The space filled with loose, cobwebby tissue.
Yes. This is the terrifying exception to the containment rule. In clinical anatomy, this specific gap is universally referred to as the danger space.
The danger space. It sounds so traumatic, but the reality of what it does is genuinely horrific, isn't it? Walk us through a scenario.
Let's say a patient develops a deep neck infection. Perhaps they had a severe, untreated dental abscess in the lower jaw, or maybe a sharp fishbone punctured the back of their pharynx while they were eating.
Okay.
Bacteria breeds, pus accumulates, and it begins to melt through the tissue.
It's seeking the path of least resistance.
Always. And if that infection manages to breach the fascial boundaries and enter the danger space, the game completely changes.
Why? What happens?
Because the danger space contains no tough barriers.
Yeah.
Only that loose areolar tissue. It offers absolutely zero physical resistance to the infection.
So the bacteria hit a wide-open highway.
And gravity takes the wheel. The danger space extends from the base of the skull all the way down, unimpeded, into the posterior mediastinum.
Which is where?
That's the deep thoracic cavity right behind the heart. The danger space acts as a direct, unobstructed conduit. Pus and necrotic tissue travel straight down the neck and empty directly into the chest.
Meaning a bad toothache or a scratched throat can literally turn into a massive, life-threatening infection, suffocating the heart and lungs in a matter of hours or days.
Precisely. It's called mediastinitis, and the mortality rate is staggering.
That's terrifying.
It is. Understanding the deep cervical fascia isn't an exercise in memorizing tissue layers. It is the literal roadmap for predicting the exact trajectory of a lethal infection. You have to know where the bulkheads hold and where the trapdoors are.
Okay, that is a very sobering reminder of why this architecture matters. We've mapped the superficial layers, we've defined the SCM, and we've built the fascial bulkheads. Let's use the SCM mapmaker to dive into the first major geographic zone of the neck.
Yes, moving behind the SCM.
Right, into the posterior triangle.
If we define the borders quickly, the floor is the middle third of your collarbone. The front wall is the back edge of the SCM. And the back wall is the front edge of the trapezius muscle sweeping down your shoulder.
So it's that hollow you can feel above your collarbone, moving up toward the back of the neck. Structurally, the back of the neck isn't dealing with the visceral tubes, the food and air.
No, it's not.
The back of the neck is fundamentally a neural landscape. It's a wiring closet.
It is a highly trafficked intersection of motor and sensory cables. The sheer volume of neurology emerging here is staggering. First, you have the cervical plexus.
What does that do?
This is a network formed by the ventral rami, the front-facing branches of the first four cervical spinal nerves, C1 through C4.
And their job is primarily sensory, right? Providing feeling to the skin of the neck and upper shoulder.
Sensory to the skin, yes, but also vital motor commands to some of the deep neck muscles.
Okay.
But delving deeper into the floor of this triangle, you find something even more massive. The roots and trunks of the brachial plexus.
This is the main power grid for the arm.
Yes. These are the nerve roots from C5 to T1. They exit the spinal cord, squeeze between the deep scalene muscles in the floor of the posterior triangle, and then bundle together to pass under the collarbone and down into the armpit.
So every single electrical signal controlling the muscles of your shoulder, your arm, your hand, your fingertips.
It all passes through the inferior portion of the posterior triangle.
Okay, if the brachial plexus is a deeply buried, well-protected municipal power line tucked safely under muscles and bone, I want to talk about a design choice that seems completely reckless.
Which one?
The spinal accessory nerve, cranial nerve exciator.
Yes, the accessory nerve.
This nerve's job is to supply motor power to the massive trapezius muscle on the back and the SCM in the front.
Yep.
But to get to the trapezius, it emerges from behind the SCM and then traverses diagonally across the dead center of the posterior triangle.
That's right.
And it does this superficially. It runs right within the investing fascia, barely covered by skin and a little bit of fat.
It is very exposed.
To use an analogy, if the brachial plexus is buried in a concrete trench, cranial nerve key is like running your primary high-speed fiber optic cable straight across the middle of the lawn, totally exposed to anyone running a lawnmower. Why on earth is a vital motor nerve left so incredibly vulnerable?
Well, it is a glaring structural vulnerability, but it makes sense when you view it through the lens of embryological trade-offs.
How so?
The accessory nerve has a very complex origin, pulling fibers from both the brainstem and the upper cervical spinal cord. Its pathway is entirely dictated by the embryological development and migration of the SCM and trapezius muscles.
So it's just following the muscles as they grow.
Exactly. To reach the vast expanse of the trapezius across the broad of the back, the nerve takes the most direct, geometrically efficient route across the posterior triangle.
It sacrifices armor for a shortcut.
Precisely, and the cost of this structural directness is extreme fragility. Because it lies so superficial to the deep fascia, it is notoriously prone to iatrogenic injury.
Meaning an injury caused by medical treatment itself.
Yes. If a surgeon is performing a biopsy on a swollen lymph node in the posterior triangle, or a cosmetic surgeon is operating on the neck, or even if a patient sustains a seemingly shallow laceration in a car accident,
The accessory nerve is just right there.
it is perfectly positioned to be accidentally severed.
So what happens if the lawnmower hits the cable, if CNXI is cut?
It results in total paralysis of the trapezius muscle on that side. The trapezius acts as the primary suspender for the shoulder girdle.
So without it, gravity wins.
Yes, the patient presents with a pronounced, visible drooping of the shoulder.
But it's not just cosmetic droop, is it? It destroys the mechanics of the arm.
It absolutely does. The trapezius is essential for rotating the scapula, the shoulder blade, upward. You need that upward rotation of the bone to provide clearance for the arm bone to raise.
Ah, I see.
So a patient with a severed accessory nerve entirely loses the ability to lift their arm above the horizontal plane. They can use their deltoid muscle to raise the arm to shoulder level, but they physically cannot reach up to grab a cup from a high shelf or comb their hair.
It is a devastating functional loss from a tiny superficial nick. It perfectly illustrates the rule where nerves travel superficially, function becomes fragile.
A very apt rule.
Before we leave the neural landscape of the posterior triangle, there is one more wire we have to trace: the phrenic nerve. Medical students always learn the rhymes C3, 4, and 5, keep the diaphragm alive.
And it is one of the most accurate mnemonics in anatomy. The phrenic nerve is assembled from branches of the cervical spinal roots C3, C4, and C5.
Where does it go from there?
It forms deep in the neck, lies directly flat on the anterior surface of a deep muscle called the anterior scalene, thankfully pinned safely beneath the prevertebral fascia, and then descends straight down into the dark cavern of the thorax to reach the diaphragm.
And it is the sole source of motor power to the diaphragm. If the phrenic nerve is cut, you cannot pull air into your lungs, you stop breathing.
Correct.
But it's not just a one-way motor wire, is it? It also carries sensory fibers back from the deep chest, for the pleura lining the lungs, the pericardium wrapping the heart, and the central part of the diaphragm.
Yes, it is a mixed nerve.
And this dual role leads to a fascinating neurological glitch regarding referred pain.
Referred pain is essentially a cross-wiring issue in the central nervous system. To understand it, we have to look at the origins.
Okay, let's look at the wiring.
The phrenic nerve comes from C3, C4, and C5, but the cervical plexus also gives off sensory nerves called the supraclavicular nerves.
Yeah.
And where do they originate? C3 and C4.
So they share the exact same electrical junction box in the spinal cord.
Exactly. Now, the supraclavicular nerves supply physical sensation to the skin over your shoulder and collarbone.
Right.
Imagine a patient develops pleurisy, a severe inflammation of the lining of the lung, or perhaps they rupture their spleen and blood pools under the diaphragm, severely irritating it.
The phrenic nerve detects the chemical burn of that irritation and screams for help.
It fires a massive distress signal up the wire, back to the C3, C4 segments of the spinal cord. The brain receives this intense signal.
But here's the glitch, right?
Yes. The brain is not evolutionarily accustomed to feeling sharp pain originating from the diaphragm. It doesn't have a good spatial map for diaphragm pain.
But it does have a map for the shoulder.
Very much so. It is very accustomed to receiving sensory data from the skin of the shoulder via those supraclavicular nerves.
So the brain looks at the signal coming into port C3, C4, assumes it must be coming from the shoulder, and projects the feeling of pain there.
Yes. The brain misinterprets the caller ID. The patient arrives in the emergency room complaining of severe, sharp pain in their shoulder tip, completely unaware that their actual emergency is an internal hemorrhage or an inflamed lung deep in their torso.
That is incredible. The nervous system lying to the brain to make sense of the wiring. Okay, so we've navigated the fragile wiring closet of the posterior triangle.
Now for the front.
Let's cross the SEM mountain range and move into the front of the neck, the anterior triangle. If the back was all about electricity and cables, this front space is all about plumbing, pressure, and viscera. It is the vital corridor.
The anterior triangle is defined by the anterior midline of the neck, the lower border of the jawbone superiorly, and the front edge of the SCM behind it.
It's quite a large space.
It is. And within this massive triangle, the muscles subdivide it into smaller zones, the submandibular, submental, muscular, and carotid triangles.
I want to focus on the muscular triangle first because it houses the strap muscles, the infrahyoid muscles.
Yes, the sternohyoid, sternothyroid, thyroid, and omohyoid.
Right. These are long, flat bands of muscle running vertically up the front of the windpipe.
If I think about the mechanics here well, the hyoid bone is unique. It's a bone in the neck that doesn't articulate with any other bone.
That's right. It is a floating anchor point.
So if you want to use the hyoid bone as a lever to pull the larynx up when you swallow, to tuck the airway under the tongue so food doesn't go into the lungs, you have to have muscles pulling from above.
The suprahyoid muscles, yes.
But if you pull it up, you need a way to pull it back down to reset the system. That is the exact mechanical role of the strap muscles. The suprahyoid muscles contract during a swallow, violently pulling the hyoid and the larynx upward and forward, sealing the airway off from the tumbling food bolus.
And then?
Once the food passes into the esophagus, the infrahyoid strap muscles, which are anchored down on the sternum and collarbone, contract. They act as the mechanical reset, firmly pulling the hyoid and larynx back down to their resting positions so you can resume breathing.
They are the biomechanical anchors of the visceral column. That's beautifully simple. But moving laterally from the muscular triangle, we enter the undisputed star of the anterior neck, the carotid triangle.
This is the hub of survival.
This is where we find the carotid sheath we built earlier, running deep beneath the edge of the SCM. Inside, you have the common carotid artery, carrying a massive, high-pressure volume of oxygenated blood straight from the aorta.
And right around the level of the upper border of the thyroid cartilage, the Adam's apple, the common carotid artery bifurcates. It splits into two.
The internal carotid and the external carotid arteries, and there is a very strict division of labor between these two pipes, isn't there?
An absolute division. The internal carotid artery is the brain's dedicated, uninterrupted supply line. It gives off absolutely zero branches in the neck. None.
Not at all.
None. It travels straight up, enters the skull through the dense bone of the carotid canal, and feeds the cerebral hemispheres.
And the external carotid?
The external carotid artery, conversely, is the supplier for the face, the scalp, and the neck itself. It immediately begins giving off branches, 6 collateral branches like the superior thyroid, lingual, and facial arteries, and 2 terminal branches to vascularize everything outside the cranial vault.
When I look at the carotid sheath, packing the carotid artery, the massive internal jugular vein, and the vagus nerve into one tight fascial tube, I think of city planning.
Ah, how so?
Imagine you're building a city, and instead of routing utilities safely across different streets, the planners dig a single narrow trench down the main avenue, and they bury the high-pressure water main, the main sewage return line, and the city's master fiber optic power grid right on top of each other.
That sounds like a disaster waiting to happen.
Exactly. It is incredibly efficient for saving space, but it turns any localized trauma into a catastrophic multi-system failure.
That is exactly the clinical reality of the neck. A single penetrating wound to the carotid sheath, say, a stabbing or a shrapnel injury, doesn't just cause massive arterial hemorrhage from the carotid.
What else does it do?
It simultaneously disrupts cranial venous return by severing the jugular and destroys parasympathetic control to the heart and viscera by severing the vagus nerve. The architecture creates an environment where small insults yield systemic collapse.
But the carotid bifurcation isn't just a junction of pipes. It's actually an active monitoring station for the blood itself.
It is an inline diagnostic center. At the exact point where the internal carotid artery begins, the base of the vessel is slightly dilated. The swollen area is called the carotid sinus.
What's special about it?
The wall of the sinus is thinner than normal and packed tightly with baroreceptors, specialized pressure sensors, innervated by the glossopharyngeal nerve. They constantly monitor the physical stretch of the arterial wall to determine blood pressure.
So it's a mechanical stretch sensor.
Yes. And just adjacent to the sinus, sitting in the cleft of the bifurcation, is a tiny reddish-brown structure called the carotid body.
And that does something different.
Very different. This is a chemoreceptor. It tastes the blood. It monitors the partial pressure of oxygen, carbon dioxide levels, and blood pH, constantly updating the brainstem on the chemical status of the blood heading to the brain.
It's an incredibly elegant feedback loop. But this brilliant design has a mechanical glitch, doesn't it? The carotid sinus syndrome.
It does. Because these baroreceptors are designed to lower heart rate and dilate blood vessels if they sense blood pressure spiking too high, they trigger a parasympathetic reflex.
Okay, that sounds helpful.
It is, normally. But in some individuals, the carotid sinus becomes pathologically hypersensitive.
So it overreacts to the slightest stretch.
It overreacts to external mechanical pressure. For these patients, the pressure of the pulse inside the artery isn't the trigger. The trigger comes from the outside.
Like what?
Something as benign as turning their head too sharply to back of a car, or wearing a stiff shirt collar and a necktie tied too tightly, physically presses against the carotid sinus.
And the sinus registers that physical pressure as a massive, dangerous spike in internal blood pressure.
Exactly. The sensors misinterpret the external squeeze as an internal crisis. They fire an emergency signal to the brainstem.
And how does the body react?
The brainstem instantly triggers a massive parasympathetic reflex via the vagus nerve. The heart rate plummets dramatically. Systemic blood vessels dilate wide open. Blood pressure drops to the floor in a matter of seconds.
And with no blood pressure, the pump can't get oxygen up against gravity to the brain.
Right. The brain is suddenly deprived of oxygenated blood, and the patient experiences sudden syncope. They completely lose consciousness and collapse to the floor. All because a stiff collar squeezed a nerve ending.
The biological tax of a tightly packed corridor. Let's dive even deeper into this visceral space. Deep to the strap muscles, wrapped tightly in the pretracheal fascia, we find the master regulator of human metabolism.
The thyroid gland.
Yes, along with the parathyroids and the larynx.
Structurally, the thyroid gland sits draped over the anterior and lateral surfaces of the upper trachea and the cricoid cartilage.
What does it look like?
It consists of a bulky right and left lobe connected across the midline by a bridge of tissue called the isthmus. Sometimes you even see a small pyramidal lobe extending upward, which is a remnant of its embryological descent from the tongue.
I notice in the anatomical diagrams that the blood supply to this gland is described as exceedingly rich. It looks like a dense thicket of red vessels wrapping the organ.
Oh, it is massively vascularized. It receives blood from two major separate arterial systems.
Which ones?
The superior thyroid artery descends from the external carotid up high, and the inferior thyroid artery ascends from the subclavian artery down low. They form rich anastomoses weaving a net of blood around the gland.
Why does a relatively small gland, maybe weighing 20 grams, need a blood supply rivaling major organs?
Because of the physics of hormone distribution. The thyroid produces thyroxine and calcitonin, hormones that dictate the basal metabolic rate of virtually every single cell in the human body.
Right.
To orchestrate a systemic metabolic shift, those hormones cannot slowly seep out. They must be immediately and massively dumped into the systemic circulation. A vast, high-volume vascular bed is the only way to achieve that rapid systemic distribution.
Okay, let's look at the nervous system wrapping around this area. This is where we encounter an evolutionary quirk that is, frankly, bizarre. We need to trace the recurrent laryngeal nerves.
The recurrent laryngeal nerves are critical. They are branches of the vagus nerve, and their job is to supply motor power to the intrinsic muscles of the larynx.
Meaning they control the voice box.
Yes, they control the tension of the vocal cords. You need them to speak, and you need them to open the airway to breathe. But their physical pathway to reach the larynx is profoundly asymmetrical and circuitous.
Let's track them. The vagus nerve descends from the brain, travels down the neck in the carotid sheath, heading for the chest. What happens on the right side?
On the right side, as the vagus passes the root of the neck, the recurrent laryngeal branch splits off. It loops physically under the right subclavian artery, makes a U-turn, and ascends back up the neck, traveling in the groove between the trachea and the esophagus to finally reach the larynx.
Okay, looping under the collarbone area. It's a detour, but fine. But the left side? The left side is insane.
The left side is a marvel of embryological compromise. The left vagus nerve drops all the way down into the deep thoracic cavity. The left recurrent laryngeal nerve branches off deep in the chest, loops entirely under the arch of the aorta right next to the heart, and then must travel all the way back up the entire length of the neck to reach the larynx.
Wait, so the signal from my vocal cords travels from my brain, past my vocal cords, all the way down into my chest, loops around my heart, and then climbs all the way back up to my Adam's apple.
That is exactly the route.
Why on earth is it designed with such a massive, inefficient loop?
It is an artifact of our evolutionary past and embryonic development. In early embryonic stages, the heart and the great vessels originate much higher up, basically in the neck area.
Okay, so everything starts out close together.
Yes. At this stage, the nerves to the larynx take a short logical path, hooking slightly under these developing vessels. But as the embryo matures, the heart and the aortic arch undergo a massive physical descent into the thoracic cavity to make room.
And they drag the nerve down with them.
Exactly. The nerve is physically tethered underneath the aorta. As the aorta descends into the chest, the nerve has no choice but to stretch and stretch and stretch, forming this massive, anatomically inefficient loop.
It's like dragging a cord caught under a descending elevator.
That is a brilliant way to put it.
It's a biological compromise born from development. Now, let's look at the physical constraint of the thyroid gland itself. I look at its anatomy. It is firmly wrapped around the cartilage of the trachea.
It is indeed.
It has the tough strap muscles holding it tight in front, and the immovable spinal column behind it. If the thyroid gland becomes diseased and hypertrophies, if it swells and grows, it has nowhere outward to expand. It's trapped. It's like a python wrapping around a vital pipe.
That is a highly clinically accurate, if terrifying, mechanical analogy. When the thyroid gland enlarges abnormally, a condition we call a goiter, the rigid fascial and muscular boundaries of the neck refuse to yield.
So where does it go?
The gland cannot bulge very far forward, so it is forced to expand inward, crushing the trachea and inferiorly plunging down through the thoracic inlet into the chest, an intrathoracic goiter.
So a patient's own hyperactive metabolism is mechanically crushing their airway.
Yes. They present with severe dyspnoea or difficulty breathing, not because their lungs are failing, but because the airway pipe is being physically squeezed shut by the expanding mass.
So if a goiter is crushing the airway, or if a malignancy develops, the surgical solution is a thyroidectomy, removing the gland.
That is the standard intervention.
But reading about the anatomy of this area, a thyroidectomy sounds less like a standard surgical procedure and more like navigating a biological minefield blindfolded.
A thyroidectomy requires profound anatomical precision, primarily because of the company the thyroid keeps. The surgeon faces 3 distinct catastrophic risks while attempting to remove this bloody, swollen gland. First, the parathyroid gland.
These are the calcium regulators, right?
Yes. There are usually 4 of these tiny, yellowish oval glands, roughly the size of an apple seed. They are embedded right on the posterior surface of the thyroid lobes.
And what do?
Their sole job is to secrete parathyroid hormone, which tightly regulates blood calcium levels.
And because they are the size of seeds and embedded in the tissue, they are incredibly hard to see.
They look almost identical to small lobules of fat or thyroid tissue. If the surgeon is too aggressive and accidentally removes all 4 parathyroid glands along with the thyroid, the patient's blood calcium level catastrophically crashes.
And that's bad because
Calcium is required for nerve conduction and muscle contraction. Without it, the patient goes into fatal tetany, massive, uncontrollable, spasmodic muscular contractions. The muscles of respiration seize, and without immediate intravenous calcium, it is lethal.
so the surgeon has to meticulously dissect and preserve tissue the size of a seed while removing a bloody organ the size of a fist. What is the second minefield?
We just discussed the recurrent laryngeal nerves. Remember, they ascend in the tracheoesophageal groove.
Right.
As they approach the larynx, they pass intimately between the terminal branches of the inferior thyroid artery, the very artery the surgeon must clamp and tie off to stop the gland from bleeding.
So the nerve is physically woven through the blood vessels you have to cut.
It is a true surgical trap. The surgeon must ligate the pulsing artery without crushing, stretching, or tying off the nerve.
And if they fail?
If the recurrent laryngeal nerve is damaged unilaterally on one side, the patient suffers severe hoarseness because one vocal cord is paralyzed. But if the surgeon damages both nerves, say, during a total thyroidectomy, both vocal cords lose their tension.
What does that mean for the patient?
They can snap shut into the midline, causing acute, complete respiratory obstruction right there on the table.
Oh my goodness. And the third risk isn't even structural, is it? It's physiological, the thyroid storm.
Yes. The thyroid gland stores massive amounts of pre-synthesized thyroid hormone in its follicles. The physical trauma of a surgeon handling, squeezing, and dissecting a hyperactive, diseased gland can mechanically rupture those follicles. This forces a massive, sudden surge of thyroid hormone directly into the bloodstream all at once.
Like squeezing a sponge full of adrenaline.
It triggers a thyrotoxic crisis. The patient's body is thrown into a sudden, explosive, hypermetabolic state. The heart races into extreme arrhythmia, temperature skyrockets, delirium sets in, and it can rapidly progress to cardiovascular collapse and death, if not aggressively managed.
It is staggering how high the stakes are in just a few cubic centimeters of tissue. So we have mapped the surface, we've built the fascial compartments, we've explored the neural wiring in the back, and the visceral, bloody plumbing in the front.
We've covered a lot of ground.
To complete our structural model, we must descend to the deepest roots of the neck, where the neck anchors to the thorax, dictating the flow of blood and sympathetic signals to the arm and the head.
This deep root architecture is entirely defined by the relationship between the scalene muscles and the subclavian vessels. We have 3 scalene muscles on each side, the anterior, middle, and posterior scalenes.
Where are they?
They originate up high on the transverse processes, the cervical vertebrae, and angle down to insert onto the first and second ribs.
Structurally, what is their day job?
They are accessory muscles of respiration. When you take a deep, forced inhalation, they contract and pull the first 2 ribs upward, expanding the top of the rib cage.
But geographically, their placement creates a severe bottleneck. Specifically, the gap between the anterior scalene and the middle scalene.
Yes, it is a very tight space.
Because the massive cables we talked about earlier have to get through there.
Exactly. The roots and trunks of the brachial plexus, the entire nerve supply to the arm, must squeeze through this exact, narrow, muscular cleft. And they don't go alone.
Who do they go with?
They are accompanied by the massive subclavian artery, pulsing with high-pressure blood for the upper limb.
Let's crack the plumbing here, because the subclavian vessels have a classic defining relationship with the anterior scalene muscle.
It is the defining landmark of the deep neck. The anterior scalene muscle acts as a physical barrier separating the artery from the vein.
So they don't travel together.
No. The subclavian artery passes behind the anterior scalene, squeezing through that tight cleft with the nerves. The subclavian vein, however, takes an entirely different, much more superficial route. It passes in front of the anterior scalene muscle.
Okay, I have to point out what seems like another massive engineering oversight here. The subclavian vein is passing in front of the scalene.
Yes.
That means it is lying directly over the top of the first rib, situated immediately beneath the middle third of the collarbone, the clavicle. It is completely superficial, trapped directly between a layer of skin and hard bone.
You're seeing the danger.
Well, if I fracture my collarbone, which mechanically is one of the most common fractures in the human body, especially in contact sports or falls, wouldn't the jagged, downward-pointing bone splinters just slice right into that massive, thin-walled vein?
You have identified a critical, lethal vulnerability The vein is massive, and a laceration there would cause catastrophic internal bleeding and allow air to be sucked directly into the heart.
Seems like a huge design flaw.
It would be a fatal design flaw, if not for a brilliant, tiny piece of anatomical evolution. Directly on the underside of the clavicle, interposed physically between the hard bone and the fragile subclavian vein, is a very small, fleshy muscle called the subclavius.
The subclavius, what does it do?
In terms of moving the skeleton, almost nothing. Its mechanical action is weak. Its entire functional purpose in the modern human is essentially to act as a physical cushion, an internal airbag.
Really? Just an airbag?
Yes. When the clavicle fractures and bows downward, the thick, fleshy belly of the subclavius muscle acts as a barrier, catching the jagged bone splinters and dramatically reducing the likelihood that they puncture the underlying vein.
That is incredible. A muscle repurposed entirely as a Kevlar vest for a vein. But what about the structures trapped behind the anterior scalene? The artery and the nerves in that narrow cleft. They have their own mechanical vulnerability, don't they? Thoracic outlet syndrome.
Yes, because they are navigating a rigid, narrow triangle formed by muscle and bone. If the volume of that space is reduced, the structures inside get crushed.
How does the space get reduced?
This can happen if the scalene muscles spasm and hypertrophy from chronic poor posture or from the congenital presence of an extra cervical rib extending abnormally from the 7th cervical vertebra.
The space shrinks and the pressure rises.
Like stepping on a garden hose, it physically chokes the subclavian artery against the first rib, causing ischemia, a lack of oxygenated blood flow to the arm. The patient's hand becomes cold, pale, and intensely painful.
And what about the nerves?
Simultaneously, the crushing of the brachial plexus nerves causes severe neurological symptoms: paresthesia, tingling, numbness, and profound weakness in the hand muscles. The bottleneck simply becomes too tight for the traffic.
There's one last critical system we need to integrate into this deep root architecture: the cervical sympathetic trunk. This is the unconscious fight-or-flight wiring for the head and face.
And its anatomical journey is unique. The sympathetic nervous system, the system that dilates your pupils to let in light, makes you sweat, and constricts blood vessels, originates entirely in the thoracic and lumbar segments of the spinal cord.
Wait, there are absolutely no sympathetic nerve fibers originating in the cervical spinal cord of the neck.
None whatsoever.
So the brain says, I'm terrified, dilate the pupils, but the signal has to originate in the chest.
Exactly. So to get sympathetic control up to the eyes, the sweat glands of the face, and the cerebral blood vessels, the sympathetic trunk must ascend.
How does it get up there?
It travels from the thorax straight up through the neck, resting deep beneath the carotid sheath, pinned right against the pervertible fascia covering the spine.
It climbs the ladder, and it has relay stations along the way.
Yes, 3 ganglia housing millions of cell bodies where the nerves synapse. The superior cervical ganglion at the very top near the skull, the small middle cervical ganglion, and the inferior cervical ganglion at the base of the neck.
Okay, I think I've heard of the stellate ganglion too.
Yes. Often the inferior ganglion fuses with the first thoracic ganglion to form a large star-shaped mass, which is called the stellate ganglion.
What happens if this sympathetic trunk is mechanically damaged? Say, a surgeon is working deep in the neck, or a massive lung tumor grows upward and compresses the stellate ganglion.
Disrupting the cervical sympathetic trunk results in a classic neurological presentation called Horner syndrome.
What does that look like?
Well, because you have severed the sympathetic fight-or-flight tone to that side of the head, the parasympathetic rest and digest system takes over unopposed.
The physiological balance is broken.
Completely. The patient presents with a very specific triad of clinical signs on the affected side of the face. First, ptosis. This is a drooping of the upper eyelid because the superior tarsal muscle, a sympathetic smooth muscle that helps hold the eye wide open, is paralyzed. Second, meiosis.
And meiosis is?
A permanently constricted pupil because the sympathetic pupillary dilator muscle fails, leaving the parasympathetic constrictor to clamp the pupil down to a pinprick. And third, anhydrosis.
Sweating.
Or lack thereof. A complete lack of sweating on that side of the face because the sweat glands lose their sympathetic drive.
Drooping lid, pinned pupil, totally dry skin. Horner syndrome. A deep, hidden neurological short circuit presenting visibly right on the surface of the face.
It's a striking clinical picture.
We've covered an immense amount of ground today. If we zoom out and summarize this architecture, the neck isn't just a junction box. It is a sheer engineering marvel.
Truly.
We've seen how fascial bulkheads dictate the lethal spread of disease down to the heart, We've seen how a single muscle like the SCM acts as a geographic map maker to navigate the surface. And we've seen how the extreme cramped proximity of vital nerves, viscera, and high-pressure vessels makes every single surgical intervention a high-stakes, millimeter-precise operation.
It is the ultimate study in biological efficiency under constraint. But before we finish, I want to pose a final philosophical thought regarding this architecture.
Please do.
If we connect all these vulnerabilities, the exposed spinal accessory nerve running across the lawn, the easily compressed carotid sinus that can make you faint from a tight collar, the delicate recurrent laryngeal nerves stretching over huge, absurd distances just to make a sound, we have to ask why.
Why is it built like this?
Yes.
Yeah.
Why is the neck built with such profound clinical vulnerabilities compared to the unyielding fortress of the skull or the robust bony cage of the thorax?
What's the evolutionary trade-off for all this fragility?
The trade-off is communication and awareness. We traded thick, bony, impenetrable armor for a multi-axial, incredibly flexible joint.
Wow.
We gave up a protective shell so that we could instantly violently turn our heads to track a predator, locate the origin of a sound, or lock eyes with a threat.
That makes total sense.
We gave up rigid protection so that our larynx could slide and move freely to create the complex mechanics of human speech, and so that our facial nerves could animate our expressions to communicate emotion and intent. Every single clinical vulnerability we discuss today is simply the biological tax we pay for the freedom of movement, the power of speech, and the depth of human expression.
The biological tax for expression. That is a brilliant way to frame the mechanics. Okay, before we wrap this deep dive, I want to play a quick game. Let's do some rapid-fire clinical mysteries to cement what we've learned.
I'm ready. Let's trace the anatomy.
Mystery number 1. A 45-year-old patient walks in holding their arm. They were in a bar fight and suffered a deep slicing wound from a broken bottle to the side of the neck, right behind the SCM muscle. The bleeding stopped, but now they cannot physically shrug their shoulder on that side, and they're completely unable to lift their arm high enough to comb their hair. The arm just hangs heavily. What did the glass cut?
The glass severed the spinal accessory nerve, cranial nerve XUA. The wound location behind the SCM in the posterior triangle is the prime real estate for this nerve. Because it runs so superficially in the investing fascia, like that exposed cable on the lawn, the glass easily sliced it. The loss of trapezius function destroys the upward rotation of the shoulder blade, making raising the arm above the horizontal impossible.
Spot on. Mystery number 2. A patient is brought in with an incredibly high fever and massive chest pain. Upon taking the history, you find out they had a severe, untreated abscess in their lower molar a week ago. Scans show a massive pool of infected pus surrounding the heart and the posterior mediastinum. How did a toothache get into the chest without destroying the organs in between?
The infection found the danger space. It eroded through the local fascial boundaries in the jaw and entered the loose areolar tissue between the two laminae of the prevertebral fascia. Because this space offers absolutely zero physical resistance, the infection just followed gravity. It traveled straight down this anatomical highway, bypassing the visceral organs entirely, and emptied directly into the thoracic cavity.
A terrifying highway. Okay, mystery number 3. A surgeon is performing a right-sided thyroidectomy to remove a massive goiter. They successfully remove the gland, but when the patient wakes up, their voice is a raspy, weak whisper. They have severe hoarseness. What vital structure was caught in the crossfire?
The surgeon likely damaged the right recurrent laryngeal nerve. As the surgeon clamped and tied off the inferior thyroid artery to stop the bleeding, they either stretched, crushed, or accidentally sutured the nerve. Because the nerve physically weaves right between the branches of that artery and the tracheoesophageal groove, any imprecision destroys the motor supply to the right vocal cord, leaving it paralyzed and causing the hoarseness.
Mystery number 4. A dentist is preparing to extract a tooth. They lean the patient back in the chair to a semi-supine position. The dentist suddenly pauses, noticing a massive, pulsing blue vessel bulging all the way up the side of the patient's neck, crossing diagonally over the SCM muscle. The dentist immediately halts the extraction and tells the patient to go to the emergency room.
The dentist is looking at a severely engorged external jugular vein. In a reclined position, it should be relatively flat. Severe engorgement means venous pressure is backing up from the chest. The dentist has spotted the classic signs of right-sided heart failure. The right atrium cannot pump blood forward into the lungs, the pressure travels backward up the vein, and the EJV acts as a visible manometer broadcasting the failing pump.
Brilliant catch by the dentist. Last one, mystery number 5. A patient is recovering from a deep invasive surgery to remove a tumor resting on the cervical spine near the base of the neck. Postoperatively, the nurse notices the patient's face looks strange. The right upper eyelid is drooping heavily. When the nurse shines a light, the right pupil is pinned incredibly small and won't dilate. And curiously, the right side of the patient's face is completely dry, while the left side is sweating normally. What is the syndrome?
That is the classic triad of Horner syndrome. The surgeon had to dissect near the prevertebral fascia and damage the cervical sympathetic trunk. By severing that ascending sympathetic wire, the patient lost the muscle tone to hold the eyelid up, resulting in ptosis. They lost the pupillary dilator, allowing the parasympathetic system to pin the pupil in meiosis. And they lost the sympathetic drive to the sweat glands, causing anadrosis. The deep wire was cut, but the short circuit shows entirely on the face.
Amazing. We have navigated the layers, the spaces, the wiring, and the incredibly high-stakes reality of the neck. As you go about your day, don't just think of the neck as a passive tube holding up your head. Remember that every time you nod, your SEM is firing, your fascial planes are sliding scenically over your trachea, and your carotid sinus is actively recalibrating your heart rate to keep you conscious against gravity. It is a symphony of biology, engineering, and evolutionary compromise. Here are the details of this episode.
The neck conduit, compass, and crossroads. Byline, where the head meets the body not as a junction, but as a living corridor of passage, protection, and precision.